Hello, everyone. I'm a neurologist by training, so I'd like to switch gear a little different aspect, actually the biased here. Everybody is talking about the acute condition, but I'd like to talk more about the chronic long-term condition. So the benefit of last speaker is that much of the introduction has saved. So why we call COVID-2? So actually the SARS COVID-1 was named after 2002 outbreak of SARS. Then the COVID-19 is termed the new coronavirus 2019, caused by the so-called SARS-CoV coronavirus 2. So we call it COVID-19. So as Mina has already shown that, I Googled this morning that is updated version. So as Mina has already mentioned that thanks to the previous SARS infection, we already know that how the coronavirus entered the host tissue cells. Using with the aid of transmembrane serine protease, the angiotensin converting enzyme 2 receptor, the contact point, and as you already know, is COVID-19 is not only the respiratory disease, but also the many organs involved. So actually it's multi-organ dysfunction has been shown. So the clinical presentation of COVID generally is very, very age dependent. So the youngsters almost all the youngsters has no symptoms at all. So we call it asymptomatic disease. The age is the major risk factors, and can determine whether the patient shows any symptoms or not. So the children has almost the children has asymptomatic, but the young adult suffered a very mild disease, like the symptom is fever, fatigue, dry cough, and malaise. And at the time, the chest X-ray shows the typical of ground glass opacity, which is a hint of pneumonia. When it comes to the age over 60, the more severe symptoms appear, and the most critical period is the oldest old patient. So they suffer from the acute respiratory distress syndrome and acute cardiac injury and multi-organ failure, which is only managed by the ICU. See, most of the case of the COVID-19, the patients suffered the acute symptom, but eventually most of them recovered from the initial attacks without any serious sequelae. However, up to 25% of the initial recovery, they show the lingering or persistent clinical symptoms known as long COVID syndrome. So based on the WHO data, currently at least 77 million people suffered from the long COVID syndrome. But the concept of long COVID is still evolving. So WHO defined the long COVID syndrome using the Delphi method, the continuation or development of new symptoms 3 months after the initial SARS-CoV-2 infection, with these symptoms lasting for at least 2 months with no other explanation. So the different health authority coined the different term, like the post-COVID condition, long-haul COVID, post-acute COVID-19, even chronic COVID. Recently coined the term post-acute sequel of SARS-CoV-2, so-called PASC. This is a different definition of the various healthcare organizations. What is the common long COVID syndrome? It's a general symptom is constitutional symptoms, extreme fatigue, tiredness, which is interfered with everyday life. Then symptoms get worse after physical or mental effort. We call it post-exertional malaise. And many respiratory and heart symptoms, even digestive symptoms, are more or less focused on the neurological symptoms. As the patients complain of difficulty thinking or concerning, we call it brain fog. And some patients shows definite depression or anxiety and relentlessness. And most of them complain of sleep problems and cruciating headache. And the dizziness when you stand up, we call it postural, due to postural hypotension, then lightheadedness, so the postural dizziness. And due to the peripheral involvement, patient complains of pins and needles sensations. And as you know, well, the decrease in the ability to smell or taste is a typical or symptoms of the, COVID-19. This paper, written by the researchers working at Washington University at St. Louis, they investigate after the 1 year the onset of the COVID break, estimate the risk and burden of incidental neurological disorders at 20 months following the acute SARS-CoV infection. What they found was that the stroke, both ischemic stroke and hemorrhage stroke, was the prevalence and incidences increased. And as you know well, the brain fog is a problem. As I told you before, the pins and needles symptoms, and episodic disorder like migraine and seizure disorders, and even some patients show the Parkinsonian feature, and mood disorders, and rare symptoms and musculoskeletal disorders, sensory disorders, even Guillain-Barré syndrome. So actually, this paper is written by a science writer, and he described his own symptoms as brain fog. So we called it the various neurological symptoms. The patient with COVID symptom is termed neuro-COVID. The postulated pathomechanisms like the cytokine-associated immune dysregulation and anti-neural antibody, because autoimmune disease, and the direct or indirect neuroinvasive infection. And one of the recent theory is that the SARS-CoV-19 triggers reactivation of the latent virus, like the Epstein-Barr or herpes simplex, which can further trigger inflammatory cascades. And neurovascular dysfunctional blood-brain barrier is leading to pro-inflammatory cytokines and pro-thrombotic materials, which cause the neuroinflammation, accounts for the entire brain injury. And hypoxia and in the cellular level, hypoxemia and metabolic disturbance cause central nervous system injury further. So at the gross level, recently, a British group published in Nature, what they found, they used the UK Biobank data. The patient who suffered from COVID-19 definitely shows the thinner gray matter and decreased brain volume. So as you see here, compared to control, the brain volume and cortical thickness are greatly reduced after the COVID-19 infection. I'm more or less focused on the neurodegenerative disease. As I told you before, some patients suffered from the Parkinsonian feature, which is not a typical feature, but because most Parkinsonian disease can go long, with long duration, but in such a short period, some patients definitely suffered from the Parkinsonian feature. This probably related to the neuroinflammatory changes. Same is true the Alzheimer's disease. So also the most important mechanism of the involved in pathogenesis of Alzheimer's disease is amyloid beta protein and abnormal tau phosphorylation, but nowadays neuroinflammation is a very important one. So the last part of my talk is focused on the interactions between COVID-19 and Alzheimer's disease. The first clinically relevant issue is that does Alzheimer's disease enhance the susceptibility to COVID-19? As you know well, the highest death rate occurred in the institution. Most of them are suffered from chronic disease like the Alzheimer's disease or Parkinson's disease. So what they found was that the ApoE4 is the best known strong genetic factors causing the sporadic Alzheimer's disease. And then the patient with, oops, I'm sorry. This paper came from the Finnish group of their autopsy series. What they found was that the patient who suffered from severe COVID-19 was ApoE4 is associated with most severe symptoms, including hemorrhagic spot in the brain. And this is the same result from the Chinese people. The COVID-19 infection and disease severity in ApoE4 allele. So the Alzheimer's disease increase COVID-19 morbidity and mortality. So the contributing factors, most of the Alzheimer's patients, advanced age, and as you know well, the patient with dementia, they cannot take care of themselves because of cognitive dysfunction. And as I told you before, the ApoE4 increased the risk of severe SARS-CoV-2 infection. And increased activity of ACE2 receptor, which is normally the arsenic-converting enzyme 2 receptor is not profoundly expressed in the brain, but for some reason in patients with Alzheimer's disease, it is overexpressed, which is make them more susceptible to COVID-19. And the other way, the SARS-CoV-2 exacerbate the existing AD pathology or clinical symptoms. This paper using the Mendelian randomization method, then what they found was that COVID-19 may contribute to the development of Alzheimer's disease. So the COVID-19 may promote the initiation and the progression of Alzheimer's disease through the genetic susceptibility and viral neuroinvasion, which directly to the cognition and mood-related structures. Underlying for that is neuroinflammation again, and blood-brain barrier disruption is associated with microglias. And there is some evidence that potential amyloid precursor protein metabolism dysfunction, which result in the much more amyloid beta protein accumulation in the brain. And definitely long-term hospitalization patient shows the immobility and they show delirium. So should we expect the number of Alzheimer's disease in the coming years? This short paper published in Journal of Alzheimer's Disease, what they found that after the COVID-19, the new onset Alzheimer's disease was compared to the healthy control. The hazard ratio was 1.65, especially elderly people aged more than 85 years, and gender difference is more susceptible in women. This is how SARS-CoV-2 might cause Alzheimer's disease. Should we include a prospective trial of antiviral or immune-enhancing therapies for future to reduce the long-term COVID? I think so. Then what are the current therapeutic strategies? Actually, right at this moment, no specific therapeutic agent that can arrest or prevent long-term COVID. As like before, the strict personal hygiene, vaccination, and oral antiviral agent, and balanced diet is the key. This is currently available antiviral agent. The last, can we prevent the brain fog and neuro-COVID? Recent paper showed that treatment of COVID during the acute phase definitely decreases the post-acute sequelae of COVID. So the treatment with acute phase with steroid and antiviral agent is very useful to reduce the impact of PASC. This is the WHO recommendation for the nutrition patient with COVID-19. And so what they recommend is take as much antioxidant as possible. Recently, I found that this article, Mediterranean diet is a potential strategy against the SARS-CoV-2 infection. So if we stick to the Mediterranean diet, it can potentiate our immune system and reduce oxidative stress, reduce inflammatory responses, and eventually prevent the long-term COVID-19 through the chronic low-grade inflammation reduction. So this is the active ingredient of the Mediterranean diet. And I'd like to end my talk by raising some questions. How long does the long COVID last? I don't know, but some researchers told that in case of Parkinson's disease, will be as long as 20 years possible, because the previous viral infection, the patient with Parkinsonian feature was appeared after around 2 decades. What are the prognostic biomarkers for long COVID? Actually, I asked mostly the laboratory medicine people to solve this problem. And how soon will the precision medicine be available to target the underlying pathomechanism, like the chronic or long-term low-grade neuroinflammation? It's to be answered. So I stop there. Thank you very much.
Thanks. Thank you very much. Any comment from the audience? Do you think that in this long COVID, there is a part of the patients that in fact they are suffering from chronic fatigue syndrome, which is started by the COVID infection, like other infections? I mean, yes, for sure there is a long COVID syndrome, but sometimes I think there is a mix on that of in the physiopathological. What is your thought?
Yes,
about that?
There is lots of reports, the similar pathophysiology between the chronic fatigue syndrome and the long COVID. So in a sense, chronic fatigue syndrome is the main pathophysiology is the chronic low-grade inflammation. So same is true for the long COVID.
All right. I think it's time for lunch. Thank you very much for all the speakers.